very good evening to all my teachers, seniors, and friends, respected officials of IAP Trivandrum. Today, we are having another session of JournalClub IAP, and a very interesting topic we have taken, and a very interesting article we have taken. And today's mentor is none other than Dr. Bindusha Madam from SATH Hospital. Madam is additional professor. And the topic presentation is on short course antibiotic therapy versus long-term antibiotic therapy. So before we start the session, we have our JournalClub coordinator, Dr. Padmanabhan sir, and none other than our IAP Trivandrum President, Rugmini Madam, and our Secretary, Dr. Benno Madam. So before starting the session, we would like to hear from our respected District President, Dr. Rugmini Madam. We have also Dr. Purushothaman sir and other faculties also from like Shana sir, etc. Then over to Rugmini Madam for her opening remarks on this journal.
Good evening, respected Padmanabhan sir, Purushothaman sir, and all other friends, and Dr. Bindusha. I congratulate you for actively participating in this journal club, along with your two PGs, Dr. Ponni and Dr. Swathy. And this is a flagship program like Tuesday series of our journal club. It is going on well. Thanks to Padmanabhan sir, being the chief coordinator of journal club, and then Dr. Anju Kanmani for the efforts he is putting in for the managing the Zoom and coordinating things. Now I'm not spending much time. Let us go into the journal. Handing over the mic to Padmanabhan sir. So you want to tell something about journal club, sir?
Nothing but only thing, you don't forget Ramankutty for his contributions. Let's start.
Sorry sir, really sorry. Ramankutty sir is the star of the show. I'll rather say somehow I missed. Extremely sorry, sir.
Okay,
And,
I don't think he minds these things.
Anyway,
sorry. Let's go to the presentation. After it is over, if there is anything, I will comment. I don't want to take any time. Let's go to the presentation.
One more thing, sir. I had requested Anju Kanmani to reduce the time if possible, not to extend till 10 o'clock. So we will go directly for the journal club.
Not 10, 9 is okay.
When are going to 10 o'clock, madam? Maybe 9 or something. And we have Dr. Sir, Emeritus Professor. Sir is always there with us for this analysis and all. And right, I think we can go to the journal club. And I would also like to hear from our Secretary, IAP Trivandrum, Dr. Benno sir. Sir, over to Benno sir. Sir.
Dr. Benno.
Thank you, Anju sir. Flagship program like our Tuesdays. Is it audible?
Yes,
yeah, it is audible.
Yeah, okay, yeah. Sorry, without much time, as Rugmini Madam, IP Trivandrum President rightfully said that this is our flagship program, and I thank our sirs, Ramankutty sir, Padmanabhan sir, and which it has been taken meticulously, and thank Anju sir for all the hard effort in the work that has been put behind the journal club presentation, and thank you Bindusha Madam for this presentation for today, and all the both the PGs who are the presenter as well as the analyst who is participating in today's program. And I wish all everyone, those who are attending this journal club presentation, I hope that will be useful for you. And over to Anju sir. For the
thank you, sir. The postgraduate who is presenting today is none other than Dr. Ponni Jayan from Madam JR3 from Pediatrics Department of SATH Hospital, and the expert and the analysis is done by Dr. Swathy R, who is the JR3 in Pediatrics SATH Trivandrum. Now we will not be wasting any time. Over to Bindusha Madam. Can we start, Madam? Ponni Madam can start the sharing slides.
Yes. Anju, can you start sharing?
Good evening all. First of all, sorry for the interruption. I'm starting with the topic. I'll be doing an overview of this article. This is the title.
Next slide.
Yes.
The title of this journal is Short Course versus Long Course Antibiotic Therapy for Children with Non-Severe Community-Acquired Pneumonia, a Systematic Review and Meta-Analysis. This is a journal published in the JAMA Pediatrics on November 14th of 2022. And this is done by various authors from the Department of Respiratory Medicine, Children's Hospital in a Medical University of China. And coming to the introduction, community-acquired pneumonia is one of the most common serious infection in the children. Annually, an estimated 920,000 children younger than 5 years die of the pneumonia, and most of the deaths are attributed to the bacterial infection. Therefore, providing an effective and safe antibiotic treatment course is of great importance. Limiting antibiotic use to the shortest effective duration is also critical, but an inappropriately shortened course of therapy may lead to treatment failure, impaired lung function, or in some cases even death, which raises a vital and difficult question for the healthcare workers. How long should antibiotic be given to a child with community-acquired pneumonia? The recommended duration of antibiotics for treating community-acquired pneumonia in children by WHO and most of the national guidelines in both low and high-income countries are different. There is the need for this systematic review, that is, evidence-based recommendation can be formulated to guide the proper duration of antibiotic treatment for children with community-acquired pneumonia. And the objective of this journal is to determine whether a short course of antibiotics was non-inferior to a longer course of childhood non-severe community-acquired pneumonia. And the methods. The systematic review and meta-analysis were conducted in accordance with the Cochrane and the data sources are from Medline, MBIS, Web of Sciences, Cochrane Library, and 3 Chinese databases from inception to March 31st, 2022.
Case definition. Case definition of pneumonia, community-acquired pneumonia was defined as pneumonia occurred outside the hospital, and non-severe CAP was defined as the absence of any general danger signs like lethargy, unconsciousness, seizures, inability to drink, and not requiring referral or parenteral therapy. Next one.
Yes, ma'am.
And the outcome definition, the primary outcome was treatment failure, which was defined as persistence of pneumonia or new appearance of any general danger signs, that is elevated temperature after completion of treatment, change of antibiotic, hospitalization, death, missing more than 3 study drug doses, lost follow-up or withdrawal of informed consent. Secondary outcomes were also included. They included relapse, adverse events, antimicrobial resistance, patients and or other caregivers, absenteeism, and direct medical costs. How's the data extraction and quality assessment done? It was by grading of recommendation and recommendation assessment, development and evaluation was used to rate the quality of evidence. 2 groups of investigators extracted the data independently, and data from each study was tabulated and checked by a 3rd investigator before analysis. Statistical analysis for dichotomous outcomes. The data is represented as pooled risk ratio with 95% confidence interval and also risk differences. Continuous variables are presented as mean differences with 95% confidence interval. Non-inferiority margin has not been definitely established. However, in this study, they selected the smallest margin, that is 5%, to avoid overestimating treatment effects. Heterogeneity was assessed by I-square statistics, and the values above 50% suggested substantial in statistical heterogeneity. Mental Hansen random effect model was selected because of diverse study designs and difference in the definition of pneumonia and treatment failure. Subgroup analysis was performed in method of diagnosis of pneumonia, whether it was clinical or radiologically diagnosed. Classification of pneumonia, whether it was a fast-breathing pneumonia or chest-indrawing pneumonia. Country income level, high income or low and middle income. Age group, that is 5 to 59 months or 5 to 10 years. Then duration of antibiotics, 3 days, 5 days, 7 days, or 10 days. Type of antibiotics, amoxicillin or cotrimoxazole. Dose of amoxicillin, high dose or low dose, and frequency of administration of amoxicillin, that is twice daily or thrice daily. And data analysis was done by Stata version 15 and Raman version 5.4. And these are the results. This is the results of outcome of treatment failure. There were 9 studies which are included in this meta-analysis. And these studies were from different countries, including low-income countries like and also high-income countries. And here we can see that most of these studies had a relative risk which is varying from 1.1, 1.14, and only one study had a relative risk of 6.55. Even that included 1. And when you look at the pooled relative risk, the pooled relative risk was 1.01 with a confidence interval of 0.92 to 1.11. So all these things tell us that they regarding the short course therapy and long course therapy, there was no significant difference between the treatment incidence of treatment failure in both groups. The same thing is actually explained here. 9 randomized control trials involving 11,143 participants were included in the review, and 98% of the participants was aged between 5 to 29 months with male predominance. Actually, only one study included children above 5 years. And 8 studies reported treatment failure, and treatment failure occurred in 12.8% versus 12.6% in patients randomized to shorter versus longer course of antibiotic. Overall, a short course of oral antibiotic was non-inferior to a longer course of antibiotic with respect to treatment failure or for children with CAP with a relative risk of 1.01 and confidence interval ranging from 0.91 to 1.11. A 3-day course of antibiotic treatment was non-inferior to a 5-day. This is subgroup analysis. A 3-day course of antibiotic treatment was non-inferior to 5-day course for outcome of treatment failure. And the next is non-inferiority conducted to meet other subgroups except comparison between 3-day and 10-day course.
How are you? You are fine today?
1 second, madam.
Are you all right? You reached here in the room?
Mute somebody, madam.
Ponni, have you joined back?
Yes, madam.
Then you can take over.
I request all the participants to mute themselves actually. And if there are no further distractions, we will continue. Is it okay, madam? Bindusha, madam?
Yes. I think
Ponni
can continue.
Yeah, okay.
Anju, can you make it?
We have reached here, right?
Yeah.
Yes. Yes. Ponni can continue. Yes. You want to tell something on this, Ponni, madam?
Yes, sir.
Yeah, please.
This is the actual result of the meta-analysis. This forest plot diagram is also showing the same thing. We can continue. We can see the relative risk of the various studies. This included one of the study from our India also. That study was actually good with a fair amount of sample size. That is, and this is in detail about the study results. In the 9 randomized clinical trial involving about 11,143 patients, 98% of the participants were aged between 2 months to 59 months with a male preponderance. 8 studies with about 10,662 patients reported treatment failure, and it is significant that the treatment failure occurred in 12.8% versus 12.6% of the participants randomized to the shorter versus longer course of antibiotics. Hence, the overall shorter course of oral antibiotics was inferior to a non-inferior to a longer course with respect to the treatment failure with a relative risk of 1.01 and 95% confidence interval ranging between 0.91 and 1.1. A 3-day course of antibiotic was non-inferior to 5-day course of outcome of the treatment failure with a relative risk of 1.1 and 95% confidence interval of 0.1 to 1.5. The non-inferiority continued to be met in other subgroups also, except in comparison between a 3-day to a 10-day course. 6 studies reported a rate of relapses, but overall shorter course of antibiotics was non-inferior to longer courses. And the 5 studies reported adverse event, and the risk of gastroenteritis and the rashes were significantly lower in short group group compared to the long course group. And 4 studies reported antimicrobial resistance, but the results varied between the studies. One study reported caregiver absenteeism that was significantly lower in 5-day group than in 10-day group. And the mean medical cost of treating 1,000 cases of non-severe pneumonia was lower in a 3-day group than in 5-day group. And coming to the discussion, in the systematic review and meta-analysis, it was found that a shorter course of oral antibiotics was inferior as a longer course in treating children aged between 3 months to 59 months who had non-severe community-acquired pneumonia. Also, a shorter course of antibiotics was associated with fewer adverse effects, including gastroenteritis and rashes, and lower caregiver absenteeism, and it was associated with lower medical cost. Furthermore, the results showed that the 3-day course of antibiotic was non-inferior to 5-day course, and a 5-day course was non-inferior to a 10-day course. Compared to other similar reviews, where a simplified syndromic diagnosis of pneumonia with fast breathing was made, our review could find that non-inferiority continued to be met for patients with radiologically confirmed pneumonia that was more considered as more accurate. And most of the children was younger than 5 years, and the number of older children was small. And the result may apply only to the children between these age groups, that is between 2 months and 59 months. Furthermore, in this meta-analysis, on comparing the effectiveness of different regimens of short course amoxicillin, it was found that it is more effective when given in lower doses, that is 25 to 50 milligram per kg per day, and less frequently, that is twice daily. That is recommended by WHO also. WHO and other international organizations recommends twice daily dosing. Moreover, lower frequency could enhance adherence. And regarding the drug doses, WHO and other Pediatric Infection Disease Society recommends a higher dose of amoxicillin. That is because of the resistance of pneumococci. But with the introduction of pneumococcal vaccine, it may be plausible to consider a lower dose of amoxicillin. Nevertheless, an appropriate dose of amoxicillin is still controversial, and dosage recommendation should be based on the local susceptibility data. And regarding the effectiveness, considering the duration, WHO recommends a 3-day amoxicillin for fast-breathing pneumonia and 5-day course to treat a chest-indrawing pneumonia in children. The recommendation of 5-day course in chest-indrawing pneumonia was based on the evidence that comparing 5-day course of oral antibiotics at home and 5-day parenteral antibiotic in hospital for chest-indrawing pneumonia. This systematic review suggests a 3-day course was non-inferior to 5-day course for children with chest-indrawing pneumonia. This conclusion may be applicable only to low and middle-income countries. Although the current evidence has supported a shorter course, the optimal duration of antibiotic therapy is not one-size-fits-all, but should be individualized and consider pathogen factor and patient response to the treatment. However, in clinical practice, knowing the true pathogen responsible for community-acquired pneumonia and treating community-acquired pneumonia according to the patient's response is challenging. And further research is needed to promote individualization of the antimicrobial therapy for pediatric community-acquired pneumonia. And the limitations of the study. This review has several limitations. Firstly, they included multiple infection types. It is possible that the optimal duration of antibiotic required differs in different types of pneumonia. Secondly, the definition of pneumonia and treatment failure varied across the study, which may have led to heterogeneity in the result. Thirdly, it did not analyze the long-term outcome because of lack of data. These important long-term outcomes should be monitored in future research. coming to the conclusion, this systematic review and meta-analysis found high-quality evidence that a shorter course of antibiotics was non-inferior to a longer course for the outcome of treatment failure among the children aged 2 months to 59 months who had non-severe community-acquired pneumonia. Clinicians should consider prescribing a shorter course of antibiotic for the management of pediatric non-severe community-acquired pneumonia in accordance with the antimicrobial stewardship principles.
Okay, that was an excellent presentation, and thanks to Bindusha madam, we could hear from you like the old classes that we are having, but there were few technical glitches and all. And Dr. Ponni madam, do you want to elaborate on any previous slides? Because
miss slides discuss
okay, I think Ponni can just go through these discussions only, no?
Okay, sir. Okay.
These slides also.
Okay, sir.
Next slide.
When you can just summarize a few things from these slides. Okay.
Okay. This is regarding the eligibility criteria. This RCT, we're comparing the shorter versus longer course of therapy using same anti-oral antibiotics for the children with non-severe community-acquired pneumonia. And they excluded many studies that included only neonates or where the treatment group received different antibiotics or different doses, and publication that did not present research finding, that is an RIT review, protocols, opinions, editorial, and report. This was the exclusion criteria for this analysis. This is the method they have used. This is a study flow diagram. Almost 7,978 references were collected through the database, and that include Medline, Embase, Web of Science, and all. From this, 1,622 duplicates were removed, and the remaining 6,356 titles and abstract were screened. And after that, 6,322 were excluded. And after excluding, 34 full texted studies were assessed for eligibility.
Excuse me, madam.
Yes,
there was a slight distraction. Can you start from the beginning? This slide only.
Okay, sir.
Yes.
This is the study flow diagram they have adopted for the study. They have screened about 7,978 references from the various 22 duplicates were removed, and then after 6,356 titles and abstract were screened. Among this, 6,322 were excluded, and 34 full text studies were assessed for eligibility. As mentioned before, most of the studies were excluded as they have included only neonates, included only adults, no separate data for pneumonia, not specifically studied as community-acquired pneumonia. Antibiotics were given in different routes. Different types of antibiotics were given and different doses of antibiotic, and studies that were not an RCT. And after excluding all this, 9 studies were included in the systematic review and meta-analysis. This is the characteristics of various studies. They have included about 9 studies as mentioned before. This included a study from India also. That study is fairly good with a good sample size. That is, the sample size of about 2,188 is there. And comparing all the study, the age group is almost equivalent. That is from 2 months to less than 5 years. And the method of diagnosis includes both clinical and radiological diagnosis. And the classification of pneumonia was according to the WHO classification. Most of the study included that is chest indrawing or fast breathing pneumonia. And they also included the type of drug. That is, most of the study included amoxicillin. 2 studies included amoxicillin, and the dosage of the drugs and the frequency of dosing, whether high dose or low dose, and twice daily or twice daily. And most importantly, the duration of the drug treatment, that is comparing 3-day, 5-day versus 7 or 10 days longer courses. And the case definition, community acquired pneumonia was defined as pneumonia acquired outside the. Yes, sir.
I think Bindusha has described these slides fairly well. So, Bindusha, is there a need for repetition or shall we go to the
ഇവിടെ
analysis?
മുതൽ നമ്മൾ കണ്ടു. ഇടയ്ക്കുള്ള ഇതിന് ഫ്രണ്ടിലുള്ളത് മിസ്
Okay.
ചെയ്തുള്ളൂ.
Yes, ma'am. Thank you so much, ma'am. So, in spite of all the hurdles, we have successfully completed the salient features of this presentation. That is what I feel. And extremely sorry for all these glitches and all, because before this presentation, we usually check for all these things, but still things can happen. Now we can go to this analysis part. Madam, am I the person who is sharing?
Yes, yes. Anju, you need to share.
Yes, ma'am.
So, good evening, everyone. I'm Dr. Swathy, Junior Resident from Department of Pediatrics, Government Medical College, Trivandrum, and I'll be doing the critical appraisal of this one. Next slide, please. So, I'll be using a Prisma for critically appraising this journal. It is the preferred reporting items for systemic reviews and meta-analysis. And Prisma 2020 statement includes a 27-item checklist addressing the introduction, methods, results, and discussion sections of a systematic review report. And it also includes an expanded checklist, Prisma 2020 abstract checklist, and a revised flow diagram for original and updated reviews. And this provides updated reporting guidance for systematic reviews that reflects advances in methods to identify, select, appraise, and synthesize the studies. So first part of the title part, the title of the study is Short Course versus Long Course Antibiotic Therapy for Children with Non-Severe Community-Acquired Pneumonia, a Systemic Review and Meta-Analysis. So from the title itself, it is clearly conveyed that the study is a systemic review and meta-analysis. So next part is the abstract. In the abstract, there are different parts. First is about the title that we have already said. That title identifies the report as a systemic review. Second is the objective. The abstract should give an explicit statement of the main objective or the questions the review address. In this, the objective was clearly mentioned. The eligibility criteria. That is to specify the inclusion and exclusion criteria for the review. But in this abstract, only the inclusion criteria was clearly mentioned, while the exclusion criteria was not mentioned in the abstract part. Then the sources, information sources like the databases, registers, which were used to identify the studies, and the date when each of them was searched was also clearly mentioned. Second is the fifth one is the risk of bias, that is to specify the methods used to assess the risk of bias in the included study, they mentioned in the abstract, and the methods used to present and synthesize the results was also clearly mentioned. So in the abstract part, only the exclusion criteria was missing. So next slide, please.
Is it not changing?
Third is the yeah. It's changing. Third is the rationale. So the study has to describe the rationale for the review in the context of existing knowledge. So in the introduction part, they have clearly mentioned that there is a clinical equipoise regarding the duration of antibiotic therapy in a non-severe pneumonia in children. So they, to resolve these gaps, they have performed the systematic review and meta-analysis so as to investigate whether the short course of antibiotic was non-inferior to a longer course for the treatment of childhood pneumonia in different populations and different settings. So the rationale for the study was also clearly mentioned. Next is the objectives. So here the objective was that to determine whether the shorter course of antibiotic was non-inferior to a longer course for childhood non-severe pneumonia, and that was also clearly mentioned. Next is the eligibility criteria, the specification of the inclusion and exclusion criteria for the review and how the studies were grouped for the synthesis. So here they mentioned that they have included all the RCTs which were comparing a shorter course with a longer course of therapy using the same oral antibiotic for children less than 18 years with non-severe community-acquired pneumonia. That was the inclusion criteria. And they have excluded the trials with neonates only. Those were in trials where different antibiotics used or different doses of antibiotics used, and the publications which did not present the research findings were also excluded. The sixth and seventh part include the information sources and search strategies. So they have to specify all the databases, registers, websites, organizations, reference list, and other sources searched or consulted to identify the study and specify the date when each source was last searched or consulted. So in the study, it is clearly mentioned all the sources, and they have searched the data from inception to March 2020. And regarding the search strategy, they should present the full search strategy for all the databases, and the registers, and also any filters or limits used. So they have mentioned the search strategies, but they have not mentioned about any filters or limits, whether they have used them. So same is with this slide. 8 is the selection process. So here we have to specify the methods used to collect the data from reports, including how many reviewers have screened each report and each report retrieved, whether they worked independently, and if applicable, details of the automation tools used in the process. So here in the study, there were 2 groups of investigators who were independently performing the study selection, and any discrepancy was solved with by consultation with a 3rd investigator. So the process of selection was also mentioned in this chapter. Collection process, where we have to specify the methods used to collect data from reports, including how many reviewers have collected the data from each report. So coming on to the 9th part, it is the data. So can you show just the previous slide, the 9th slide? So we'll move with the 9th part, that is the data collection process, which specifies the methods used to collect the data from reports, including how many reviewers have collected the data from each report, whether they have worked in an independent manner or any process obtaining or confirming data from study investigators, and if applicable, the details of automation or any process. So 10B is to list and define 10 is to the data items. It includes 2 parts, 10A and 10B. We have to list and define all the outcomes for which data were sought. So in the study, the primary outcome was the treatment failure, which was clearly defined as the persistence of pneumonia or the new appearance of any general danger signs of pneumonia, elevated temperature after completion of treatment, change of antibiotic, hospitalization, death, missing more than 3 study drug doses, loss to follow-up or withdrawal of informed consent. And 10B is to define other outcomes which was studied. So 10B, we have to define all other variables for which the data were stored, and the secondary variables included relapse rates and the details regarding the drug resistance and all. 11th is the study risk of bias assessment. So here we have to specify the methods used to assess the risk of bias in the included studies, including the details of the tools used, how many reviewers have assessed each study, whether they worked independently, and if applicable, details of automation tools used in the process. So in this study, they mentioned that the Cochrane risk of bias tool was used to assess the risk of bias. And after that, they classified the risk of bias as low, high, or unclear. And if there were any disagreements in this assessment, it was resolved by the 3rd investigator. So there was a clear mention about the study regarding the risk of bias assessment. Next is the effect measures. Specify for each outcome the effect measures used in the synthesis or presentation of results. So here they have mentioned that they have used a pooled risk ratio and 95% confidence interval for dichotomous outcomes. And to facilitate interpretability, they have also used risk differences, and continuous variables were presented as mean difference with 95% confidence interval. However, the non-inferiority margin was not definitively established in this study, and they have taken it arbitrarily as 5%, which was the lowest. And the pre-specified subgroup analysis based on the following variables like method of diagnosis of pneumonia, classification of pneumonia, whether it was fast breathing or chest indrawing, the country income level, age range, duration of antibiotics, whether it was 3-day, 5-day, 7-day, or 10-day, type of antibiotics, dose of amoxicillin, and frequency of administration of amoxicillin, whether BD or TDS dose, was also clearly mentioned. 13 is the synthesis methods. And here there are multiple parts for this synthesis methods. First include, they have to describe the process which was used to decide which study was eligible for each synthesis. That was mentioned in the study. And they have to describe the methods required to prepare the data for presentation or synthesis, like how they had handled with the missing data and data conversions. But nothing regarding such methods were mentioned in the study. Then methods used to tabulate or visually display the result of individual studies and synthesis was also mentioned. And the methods used to synthesize the result and provide rationale for the choice was also mentioned. And methods used to explore the possible causes of heterogeneity among the study. It was also mentioned that is I-square statistics was used to measure the heterogeneity, and the sensitivity analysis, which was used to conduct the assess the robustness of the synthesized result. So they have also mentioned that they have conducted a sensitivity analysis and confirmed the robustness of the results. 14th is the reporting bias assessment. They have to describe the method which was used to assess the risk bias due to missing result in synthesis. They said they have assessed the risk of bias with the Cochrane risk of bias tool and classified it as low, high, or unclear. Next is the certainty assessment. They have to describe the method used to assess the certainty in the body of evidence for an outcome. And they have mentioned that grade approach was used to determine the quality of evidence. Next is the study selection. Here we have to describe the result of search and selection process from the number of records identified in the search to the number of studies included in the review, ideally using a flow diagram, and cite studies that may appear to meet the inclusion criteria, but which were excluded, and explain why they were excluded. So this flow diagram was given elaborately in the study. So here they have started from the reference studies and showed us how they concluded with the 9 studies. And next is the study characteristics. Here they have to cite each included study and its characteristic. So the characteristic of the selected studies was elaborately described in a table in the study. And the risk of bias in studies, like the present assessment of risk of bias due to missing results. So they said they have assessed the risk of bias using the Cochrane risk of bias tool. Next is the results of individual studies. So for all the outcome present for each study, we have to summarize the statistics for each group, and an effect estimate should be ideally plotted using a structure label and scopes. And for this, forest plots were used in the study. So this is the forest plot, which was showing the outcome of the treatment failure, and treatment failure had occurred in 12.8% versus 12.6% in both groups. And this is the forest plot for result of outcome of relapses. And 20 is the result of synthesis. Here, for each synthesis, the study has to briefly summarize the characteristic and risk of bias among the contributing study that was done in the study, and present the result of all the statistical synthesis conducted using the plots that was also done. And they have presented the investigation of possible causes of heterogeneity among the study results. And they have also present the result of all sensitivity analysis conducted to assess the robustness of synthesized results. 21st is the reporting biases, where we have to present the assessment of risk of bias due to missing results for each synthesis assessed. And they have mentioned that the details regarding the risk of assessment were provided in the supplement along with the journal, but unfortunately, we were not able to access them. 22nd is the certainty of evidence, present assessment of certainty or confidence in the body of evidence for each outcome. This is the confidence that the true effect is within a particular range or relative to a threshold. And they said they have assessed it using grade. Grade is grading of recommendations, assessment, development, and evaluation approach for all the outcome. And they have divided the outcomes into high, moderate, low, or very low, depending upon the certainty. Then coming on to the discussion part, the discussion part should provide a general interpretation of the results in the context of other evidence. So a general interpretation given was that the shorter course of oral antibiotics was as effective as a longer course in treating children aged 2 to 59 months who had non-severe community-acquired pneumonia. And also the shorter course of antibiotic was associated with fewer adverse events, including gastroenteritis and rash, and lower caregiver absenteeism. And it was also associated with lower medical cost. And the next part of the discussion should mention about the limitations of the evidence and review process used. So this study, the authors have mentioned there are 3 limitations. First, they have included multiple infection types. Second is that definition of pneumonia and treatment failure had varied across the studies. And this may have led to heterogeneity in results. So they have pooled the data. And third is that they said they were not able to analyze the long-term outcomes because of the lack of the data. So these 3 were mentioned as the limitations of the study. the last part, they have to discuss the implications of results for practices, policy, and future results. So the authors said that their systemic review suggested that a 3-day course was not inferior to a 5-day course, so that their current findings may allow for harmonization and simplification of the treatment courses to 3 days for both fasting and chest indrawing pneumonia in children. And also they think that their review will help to fill the evidence gap and provide a basis for evidence-based decision making. So the implications of the study was also discussed. The last part is the other information part, which include the registration and protocol, support, competing interest, and availability. So in the registration protocol, those should mention about the registration information for the review, like the register number, state, or state that the review is not registered, which was not mentioned. And also they have not mentioned where the review protocol can be accessed or the state that a protocol was not prepared. And nothing was mentioned about the amendments to information which was provided at registration or in the protocol. And the support, so they have described the sources of financial or non-financial support for the review, and the role of the funders or sponsors in the review was also mentioned. The competing interest, they have clearly mentioned that there was no competing interest of review authors. And regarding the availability of data code and other materials, here they have to mention about where they can be where it will be publicly available, the template data collection form, and data extracted from included studies, data used for analysis, and analytic code, or any other materials used in the review. That was also, the availability was also not clearly mentioned. And to conclude, so the limitations of this study that we could identify include the exclusion criteria was not mentioned in the abstract. The filters and limits which were used in the search strategy were also not mentioned. And the study has not definitely set a non-inferiority margin. And the methods used to handle and report the publication bias, a funnel plot was needed. That was also not mentioned. Details regarding registration and protocol were not mentioned. And availability of data code and other materials were also not available. So that's all. Thank you.
Okay, thank you for that excellent presentation. You have analyzed in detail and also have tried to bring out the details of certain terms which has been used regarding the statistical analysis in the study. Now we'll go to Dr. Ramankutty sir for an expert opinion on the study. Over to Dr. Ramankutty sir.
Actually, I think I will, am I audible?
Yes, sir.
Because of the poor connection, can I just switch off my video? Is it all right?
Sure, sir. Sure, sir. Please, sir.
Okay, I have some problem with the connection. Anyway, I think the presentations were excellent. They have done a very good job. And I think the selection of the paper was also excellent because no, I will restrict myself to the technical or the methodology issues. As you know, this is a meta-analysis and a systematic review. And nowadays, you know, this is considered as a separate study design. It has its own place in the type of studies, like when you say cohort studies, clinical trials. Meta-analysis and systematic reviews is another design. And actually, it is not very easy to do also. The systematic review can or may not be followed by meta-analysis. But meta-analysis has always been preceded by a systematic review. Am I connected now?
Yes, sir.
Okay. So that is a relationship. You can do a systematic review on its own and not do the meta-analysis. But you can. But if you want to do a meta-analysis, you must do a systematic review. And of course, the PRISMA guidelines, which was a very excellently presented by the junior resident who did that. Actually, you know, now you have guidelines for every type of review, every type of design, and this is the PRISMA is the particular guidelines for systematic reviews and meta-analysis. So you can just use that checklist and see how well they have done. And I think she has done an excellent job. So what I want to say is that I don't know. I mean, people can ask questions about it, but generally I will tell you a few things and then we can have a discussion. Of course, the systematic review, you have to present how you search the databases. What are the databases that you searched? What are the methods that you use to extract the information? As she said, what are the inclusion, exclusion criteria for the studies? So you have, a lot of studies, thousands of studies, and then finally distilling into 10 or 11 studies, right? So that process is very important, and that they have given that nice flow chart, how many studies were selected and what are the criteria, finally what happened. So that is very important. So that is the first thing. And then you have to look at what is known as the PICO, that is PICO. So any systematic review, you look at the PICO. PICO means, P means population, which means which are the people on which these studies were done. Here, of course, obviously, these are children. They are defined that these are children. And I means PICO. I means intervention. What is intervention that is being tested in these studies, which is obviously the short course antibiotic. And C stands for comparator. Comparator means what is it being compared against. And here it is a routine treatment or the longer term antibiotic use. And O means outcome. So what is the outcome on which you are comparing? So here, of course, they have used multiple outcomes, but generally at least one outcome has to be tested. So PICO guidelines or the PICO criteria have been met. And this is something that you would look for in any meta-analysis or any systematic review. So PICO is a very important thing that you have to keep in mind. And they have gone through the risk of bias assessment. That is another thing. Risk of bias means how good is the study. So there are several tools. They have used a particular, I think, the Cochrane tool, which actually is like a checklist. You have to look at each study and fill in what are the things that go into. So there are some questions you can just check whatever has been done, what has not been done. And then finally, you come out with an assessment of how free of bias the study is. So that is one of the important things. So the better, the more free of bias study is, you give a better weightage to that, or you understand that they have done a good job in picking the study. And they have also mentioned how the selection was done, 2 people independently looking at the studies. And then the third one, solving any differences of opinion, whether a study has to be included or included. That is very, very important. And see, this is the most time-consuming process in a systematic review. So when you do a systematic review, you must have a team. It's not something that can be done by one person, because the selection of studies has to be done by at least 2 people. Then there has to be a third person who will resolve the differences. So you need 3 people. So a team has to work at it, and it takes about 3 months or even 3 to 6 months or even longer to completely screen all the studies available. So you can even look for grey literature if it's available, and screen for all the studies that come your way. So that process itself is a very time-consuming one. So after that, you do a meta-analysis, which is a very typical statistical method. When I won't go into the details, except say that it is a study of studies. That is, you take the raw data. You don't have to use the raw data. There are software which will allow you, if you just have the effect measure and the confidence interval, you can pool the studies using the various criteria, and that is what they have done. And then there is something called I-squared, which they have mentioned. I-squared is the measure of heterogeneity. When you select several studies, they may not all be homogeneous, or they may differ from each other. So how different are they from each other is indicated by the I-squared statistic. So if they are very different, then I-squared is very high. So that gives you an impression that they are not really pooling similar studies. It may be that they are not looking at similar studies. So that is why I-squared is important. And there are two models which are used. One is called what they have used, a random effects model, and then the fixed effects model. Fixed effects model is very, very rarely used, but usually, we assume that each study is different from the other study. So then that means that you have to use the random effects model. So each study is like a random study. So you assume that it's just a random study, and then you use a random effects model. I won't go into statistical details. So I-squared is very important. Then you use the random effects model, and you produce a forest plot. To be very frank, I don't know why they call it a forest plot. It's just like one tree. It's not really like a forest, but so if you look at a forest plot, you will find that there is a line down the middle, vertical line, which indicates the null value, which means the value where if the intervention has no effect. It's neither protective nor harmful. So it is just zero in case of risk difference, and 1 in the case of a risk ratio. And then you have the diamonds, which indicate the risk ratio or risk difference, whichever you are using, how far to the one side of the line it is. And then you have a long line, which indicates the confidence interval, usually. It may even be just the standard error, but you can use various norms. So, and then finally, the size of the diamond, that is the diamond which indicates the where the odds ratio or the risk ratio is. The size of the diamond usually indicates the sample size of the study. So the larger the study, the bigger it will be. So finally, at the bottom of the plot, you will find the big diamond, which indicates the pooled value of all your studies. And that is what tells you where you stand, and recommendations and everything is based on that. So this briefly is the way you go about meta-analysis or systematic review and system meta-analysis. But you must have a very interesting question like what they have done here. A question which engages the minds of the clinicians, whether I have to do this or that, A or B. Then only that is the right situation where you look at a possibility of doing a systematic review or meta-analysis. Regarding this particular study, I personally feel it is well done, and they have looked at a very interesting question. I don't know. I'm not a practicing clinician, so I'm not able to comment on the value of the question that they are looking at, etc. But assuming that is very relevant, I think they have done a good job. So, and also, of course, there are a few flaws which has been pointed out by the person who has addressed. So that is my assessment in a nutshell. I want to once again congratulate the people who presented, because the standard of presentation has been very high. I think the young people are improving a lot. They are learning a lot of things which we never knew about on our days. I'm sorry to say, but that is how it is. Anyway, live and learn. Thank you.
Thank you so much, sir. Over to Bindusha madam for madam's thoughts. Madam, kindly share madam's thought with you.
Actually, we thought we will take this study because this is a relevant one, and actually clinicians are very interested in knowing about the treatment, and since this meta-analysis came, we thought we will discuss. I would like to hear from seniors like Padmanabhan sir, Purushothaman sir, and Shanavas sir about the topic as proper. Sir. Padmanabhan sir.
Over to Padmanabhan sir.
Okay, I will take it from what Dr. Ramankutty did in exhaust. I came to know how much difficulty they have done this meta-analysis. Am I audible?
Yes, sir.
Yes, sir.
Okay. But the point is that it's not that something which has come up recently. It is not only the WHO which is telling it. In fact, the New England Journal in 2020 or something wrote a editorial on this, and they quoted the study from Malawi, where they said the 3-day course is as effective as a 5-day course. Therefore, the advanced countries are also looking into it. It's just not the WHO which wants to treat children in the periphery like that. And the pivot study was done in UK in 2007, which was also done from multiple treatment centers. But hello. And but you should understand that even in 2022, the guidelines of the Indian Academy of Pediatrics gives a 5-day course. That is a softener of all this. That's a difficulty we have. I don't know, I think I'm right because I looked at the standard guidelines of IAP in 2022. Therefore, it gives a 5-day course. And we know that the WHO, for patients who are having only fast breathing, they give a 3-day course of antibiotic, and for subcostal recession, they are talking of a 5-day course. Therefore, there is some confusion in, even if you take, this has been guided by so much evidence have accumulated over the years, so much effort is put in meta-analysis, and clinicians have a problem in, because one size doesn't fit all. Because the reason for that is, one thing which I have a problem is in the definition of pneumonia. How can you define fast breathing as pneumonia? I don't understand that. Because majority of children with fever with fast breathing is a viral disease. And I tell my students, don't waste your antibiotic on it. But the WHO guidelines, they say that you give antibiotic, which I think is not necessary at all. And in this case, for example, they said, other than fast breathing, and they have also included radiological features. But they have not specified what radiological features they have taken up to say that this is specifically pneumonia, because you know that how do you do? Majority of the people who come with fever with fast breathing are viral infections also, and the radiology always does not differentiate also. Therefore, this is a heterogeneous population which they have identified. I still feel one size may not fit all. And further, remember one thing, they have said that there is a failure of 10 to 12%. Remember, in our practice in the treatment of pneumonia, even one case is not allowed to fail. The pneumonia death is not allowed when the patient is under your treatment, unless it is some very, very, resistant organism. Therefore, I would conclude by telling, an outstanding study done. There is evidence is accumulating very fast to say a 3-day course is enough. But there are conditions in which there are evidence, but we find it very difficult to follow in clinical practice. I would like to ask Dr. Purushottam to respond to what I have said. Thank you.
Thank you so much, sir. Over to Dr. Purushottam, sir. Sir, unmute, sir. Muted. Yes, sir.
Thank you, sir. First of all, I must confess the ignorance about this new method of I am not at all familiar with this methodology. But as a clinician, I take from the Ramankutty sir's last part, whether we can adopt as a policy matter how, even though the study is excellent, everything is convincing, when we take such an important entity which decides the mortality of the world of kids less than 5.
Sorry, sir. Kindly continue.
Such an important entity, whether it can be adopted as a policy. When I consider the death causes below 5 years, especially below 1 year, because the age-wise subpopulation analysis should have been done, and the mortality, when we consider the nutritional status, is one very important thing. Immunization status is one important thing, and breastfeeding. These are taught for all ages. These will be modifying the under 1 infant mortality in wherever they are. So these factors are not taken into consideration. About the nutrition status for in this case is not taken into consideration, and immunization also is not taken into consideration, and how much of the breastfeeding pattern is not taken into consideration. And of course, you cannot generalize all the pneumonias. The treatment of choice will be amoxicillin, because under 1 there is a dangerous group where Staphylococcus is there, and around 5 years there is the Mycoplasma, Ureaplasma, that group of organisms are there. So this will not respond to this amoxicillin at all. So whether this is a generalizable like this breakup, and whether we can go for the 3 days trial is a little bit bad. When we take directly into the practice, I'll doubt. As a clinician, I cannot accept it without considering these major factors, especially under 1 year.
Can I come in a little, 1 or 2 sentences I would like to add? Actually, this amoxicillin, previously, it was trimethoprim sulfamethoxazole. They have shifted it over to amoxicillin. And according to WHO and all world literature, it is amoxicillin. They first said 90 milligram per kg because extrapolating data from otitis media. They say that to treat this pneumonia, you will have to have a MIC above and the above MIC levels at least for 30% of the time. For this 90 milligram per kg was required, but later they said no. Well, in countries like India where the resistance is not high, and because we are now giving immunization, the resistance will come down. The lower dose, 30 to 50 milligram is enough. So these are and one thing which I find in most of the literature, many of the students who pass out of the Trivandrum Medical College come and say that if amoxicillin doesn't work, we can use cefuroxime. Actually, cefuroxime is a much inferior drug to most of the medicine, except if you are thinking Staphylococcus aureus, where it might have a slightly marginal better effect. That's what they are telling. But nobody will treat a staphylococcal pneumonia with oral antibiotic that easily. It's a very rapidly proven pneumonia. Therefore, there are so many things involved in this. And but we have to understand that it is not only the WHO which says this for the sake of the developing countries. Even the developed countries have started talking about amoxicillin as a drug of choice, and not even amoxiclav. Remember that, amoxicillin. And the dose they say is 90 milligram per kg. But in this they have written for 30 to 50 milligram is also enough. And BD dose is enough even for 30 to 50. That is a little controversial. The BD dose is actually for 90 milligram, but they are telling even 30 to 50 you can use. Therefore, there's a lot of things in this, as Dr. Purushothaman has said, and it's very difficult to generalize on this because we don't want any failures in the treatment of pneumonia. Definitely not, because we don't want any child to die under our treatment. Especially now, nobody will accept that. Okay, now back to.
Yeah, thank you, sir. Now, Bindusha madam, do you want to add anything more?
No. Actually, I would like to thank Dr. Anju Kanmani for giving us an opportunity to present this case. And also, I would like to congratulate both Ponni and Dr. Swathy, who did a very good job.
Thank you, madam. And we have other pediatricians also in the audience. So I would like to tell that they can also contribute to the discussion. And Pavati madam has about to tell something I felt.
Pavati madam is there.
Nothing more to add, Bindusha. Nothing more to add.
Thank you, madam. Okay. Now, Vijay Kumar sir, could you share your thoughts regarding the study and sir? Vijay Kumar sir.
Hello.
Yeah, sir. You're audible, sir.
Actually, I joined only in the last part of the discussion. So
Yes,
I was late in that, so I cannot make any comments.
Sir. Okay, sir.
We can conclude, I think.
We were discussing about the long and short course antibiotic therapy in pneumonia, various types of pneumonia. And now, Padmanabhan sir, Bindusha madam, are there any other similar studies from India regarding this short course?
Actually, this is a meta-analysis. They have included different studies from different states. One is from India only. It was a large study which was done in India only. And the thing is that in this meta-analysis, there are different types of studies included. Some of them were versus 3 to 5 days. Some of them were between 5 and 10 days. It's actually a heterogeneous group of studies were included in this. And also another finding that which is not very highlighted is that there was no 3-day course was found non-inferior to 5-day course. And 5-day course was found non-inferior to 10-day course. But definitely 3-day course was inferior to 10-day course. That is actually not highlighted. Just saying that non-inferiority was there between 3 to 5 and 5 to 10. There was no non-inferiority between the other 3 and 10. Okay. That is another thing.
They are giving this to even those pneumonias with the chest indrawing also. Is it not
Yes,
like that?
yes. Even for chest indrawing pneumonia, it was included. There are different studies have used different definition for pneumonia also. Some of them have included radiological also, but majority of the studies were clinical studies, which were including fast breathing and also chest indrawing.
Okay, madam. But
now, because the classification of pneumonia has changed.
Yeah, that's a great.
Moderate includes chest indrawing also. But previously, chest indrawing means severe pneumonia. Now it is moderate.
Madam, in the ARI control program, what is the present recommendation of antibiotic, madam? Is it still?
It is still amoxicillin only for non-severe pneumonia. For fast breathing and chest indrawing pneumonia, it is amoxicillin. Only those children with danger signs are included as severe pneumonia, and there they recommend parenteral antibiotic.
And when you give amoxicillin, is 5-day course or 3-day course advice?
The ARI control program recommends 3-day course of antibiotic for fast breathing pneumonia where there is low prevalence of HIV. And they recommend 5 days of antibiotic for chest indrawing pneumonia. This is the ARI
WHO recommendation.
Yeah, WHO recommendation.
But I think standard guidelines IAP 2022, I think it is 5-day course for all.
Yeah, that recommends 5-day course.
Can I say something, Anju?
Sure, sir, please, sir.
Yeah, two things. What the clinicians are saying, what I understand is, I think I agree with them in the sense when you talk of PICO, the first is P, which means population. So what they're saying is that it is not the same population they are talking about. I mean, you have children from a wide range. So we should have studies, but unfortunately there are not too many studies in each age group. So that is another problem. Unless you do so many studies, then you can't sum up the evidence. So probably you need more studies to arrive at a more definite kind of recommendation. Until then, maybe as they are saying, it will be always safe to err on the side of safety rather than go for something which is. So that is very important. But I think also I have a doubt that one of the things is that they have very clearly stated that this community diagnosed pneumonia, right?
Yes, sir.
So these are not
community acquired pneumonia. Sorry, sir. Bindusha, please.
Community acquired pneumonia.
Yes, sir.
So what I understood, I don't know, is that these are guidelines, or maybe these are things for people, or children who are not really admitted to hospital yet. So that may actually different from children who we see in the hospital. I don't know, maybe that explains this.
No, that is not the definition of community acquired pneumonia. It's a child who develops pneumonia who has not been admitted in the last 14 days in a hospital.
Okay.
If a child comes to hospital and gets admitted, in the last 14 days he was not admitted anywhere else, it becomes community.
Yeah, now I understand. Okay. So maybe I thought that maybe that explains the problem. Probably it doesn't.
Maybe it will need a lot of studies to finally get into a conclusion, and finally any change occurs in the standard treatment guidelines of IAP, as I was telling.
Yes, basically, yeah, that's right. But the populations are very heterogeneous, so that is something which keep in mind.
And Purushottam sir was telling about all the factors like breastfeeding, malnutrition, and immunization. Those are also very important, especially in an Indian situation, actually.
But any fast breathing in a malnourished child is a severe pneumonia.
Severe pneumonia. That is another.
Therefore, that doesn't come under this.
Sir. Anyway,
but if you look at the Indian study, I think they had a large number, right?
Yes.
Pretty large number, and they have randomized, and they have come to the conclusion that shorter course is quite adequate. So I don't know what to conclude, but
it was a great discussion actually. And Dr. Benno, Secretary AP. I think,
I
sir,
think
it's
we
not.
can conclude. It's
Yeah,
because it's
definitely,
already
sir.
1.5
Because,
hours.
Rugmini madam was there and madam has just left actually. I mean, it was a great discussion. There was a few technical glitches, but we were able to overcome that, and it was a great. I mean, thanks Bindusha madam for the enthusiastic participation. Because when
Very good selection.
Yeah, that is
Article.
a great selection of article, madam. Thank you so much.
Yes,
And,
yes, I adored that. I mean, it's a very good article to read also.
And I would also like to thank Dr. Purushottam sir for his valuable teachings and suggestions and great observations. And Dr. Padmanabhan sir for his contribution and research. And Bindusha madam for mentoring the postgraduates and the postgraduates, Dr. Ponni and Dr. Swathy. Your time, extremely great efforts in a very short time and have presented well, the great slides and all. And Sir was telling that it was a great presentation, so it's a great thing. We know that that is actually good, and for all those who have taken part in the discussion, and I think we will call it a day for today, and we will meet next time. Until then, have a great day. Thank you very much and good night.
Thank you. Thank you very much.